This session we will discuss nursing informatics in relation to the human-technology interface. At the end of this session, you will be able to describe the human-technology interface. What is the human-technology interface? Generally speaking, anytime a human uses technology, some type of hardware or software enables and supports the interaction. It is this hardware and software that defines the interface. In today's healthcare setting, one encounters a wide variety of human technology interfaces. Those who work in hospitals may use barcode identification cards to log their arrival time into a human resources management system. Using the same cards, they might log into their patient's electronic record, access their drugs from a drug administration system, and even administer their drugs using barcode technology. Other examples of human technology interfaces one might encounter include a defibrillator, a patient-controlled analgesia pump, any number of physiological monitoring systems, electronic thermometers, and telephones and pagers. The human interfaces for each of these technologies are different and can even differ among different brands or versions of the same device. For example, to enter into an EHR, one might use a keyboard, a light pen, a touch screen, or a voice. Healthcare technologies may present information via computer screen, a printer, or a personal digital assistant, or PDA. Patient data might also be displayed in the form of text, pictures, for example, the results of a brain scan, or even sound in an echocardiogram, and the information may be arrayed or presented differently based on roles and preferences. Some human technology interfaces mimic face-to-face human encounters. Poorly designed technology can lead to errors, lower productivity, or even the removal of a system. Unfortunately, as more and more kinds of increasingly complex health information technology applications are integrated, the problem becomes worse. However, nurses are very creative, and if at all possible, will design workarounds that allow them to circumvent troublesome technology. However, workarounds are only a Band-Aid. They are not long-term solutions. In the human factor, Vicente in 2004 cited that many safety problems in healthcare identified by the Institute of Medicine's 1999 report noted how technology used often does not fit well with human characteristics. As a case in point, Vicente described his own studies of nurses' patients-controlled analgesia or PCA pump errors. Nurses made the errors in large part because of the complexity of the user interface, which required as many as 27 steps to program the device. Vicente and his colleagues developed a PCA in which program required no more than 12 steps. Nurses who used it in the laboratory experiments made fewer errors, programmed drug delivery faster, and reported lower cognitive workloads compared to the commercial device. Further evidence that human technology interfaces do not work as well as they might is evident in the following events. Doyle in 2005 reported that when a barcoding medication system interfered with their workflow, nurses devised workarounds, such as removing the armband from the patient and attaching it to the bed, because the barcode reader failed to interpret the barcodes when the bracelet curved tightly around a small arm. Koppel and et al. In 2005 reported that a widely used computer-based physician order entry system meant to decrease medication errors actually facilitated 22 types of errors because the information needed to order the medications was fragmented across as many as 20 screens. Available medication dosages differed from those the physicians expected, and allergy alerts were triggered only after an order was written. Some human technology interfaces mimic face-to-face human encounters. For example, faculty members are increasingly using video conferencing technology to communicate with their students. Similarly, telehealth allows nurses to use telecommunication and video conferencing software to communicate more effectively and more frequently with patients at home by using the technology to monitor the patient's vital signs, supervise their wound care, or demonstrate a procedure. Telehealth technology has fostered other virtual interfaces, and such as system-wide intensive care units in which intensivists and specially trained nurses monitor critically ill patients in intensive care units, some of whom may be in rural locations. Sometimes telehealth interfaces allow patients to interact with a virtual clinician, actually a computer program, that asks questions, provides social support, and tailors education to identify patient needs based on the answers to screening questions. These human technology interfaces have been remarkably successful. Sometimes patients even prefer them to live clinicians. Human technology interfaces may present information using text, numbers, pictures, icons, or sounds. Auditory, visual, or even tactile alarms may alert users to important information. Users may interact with or control the technology via keyboards, digital pens, voice activation, or even touch. Human technology interface problems are the major cause of as many as 87% of all patient monitoring incidents. It is not always that the technology itself is faulty. In fact, the technology may perform flawlessly, but the interface design may lead the human user to make errors. Vicente in 2004 noted that technology should fit human requirements at 5 levels of analysis: physical, psychological, team, organizational, and political. Physical characteristics of the technology, for example, size, shape, location, should conform to the user's size, grasp, and available space. Information should be presented in ways that are consistent with known human psychological capabilities. For example, the number of items that can be remembered is 7 plus or minus 2. In addition, systems should conform to the communication workflow and authority structures of the work teams, to organize factors such as culture and staffing levels, and even to political factors such as budget constraints, laws, or regulations. A number of analysis tools and techniques have been developed to help designers better understand the task and the user environment for which they are designing. A number of analysis tools and techniques have been developed to help designers better understand the task and user environment for which they are designing. These are task analysis, cognitive task analysis, and cognitive work analysis. Task analysis examines how a task must be accomplished. Generally, analysts describe the task in terms of inputs needed for the task, outputs, what is achieved by the task, and any constraints on actors' choices on carrying out the task. Analysts then lay out the sequence of temporally ordered actions that must be carried out to complete the task in a flowchart. A worker's task must be analyzed. Task analysis is very useful in defining what users must do and which functions might be distributed between the user and the technology. Cognitive task analysis usually starts by identifying through interviews or questionnaires the particular task and its typicality and frequency. Analysts then may review the written materials that describe the job or are used for training and determine through structured interviews or by observing experts perform the task which knowledge is involved and how that knowledge might be represented. Cognitive work analysis was developed specifically for the analysis of complex, high-technology work domains such as nuclear power plants, intensive care units, and emergency departments where workers need considerable flexibility in responding to external demands. A complete cognitive work analysis includes 5 types of analysis: work domain, control tasks, strategies, social organizational, and workers' competencies. The work domain analysis describes the functions of the system and identifies the information that users need to accomplish their task goals. The control task analysis investigates the control structure through which the user interacts with or controls the system. It also identifies which variables and relations among variables discovered in the work domain analysis are relevant for particular situations so that context-sensitive interfaces can present the right information, for example, through prompts or alerts at the right time. The strategies analysis look at how work is actually done by the users to facilitate the design of an appropriate human-computer dialogue. The social organizational analysis identifies the responsibility of various users, for example, doctors, nurses, clerks, or therapists, so that the system can support collaboration, communication, and a viable organizational structure. Finally, the worker competencies analysis identifies design constraints related to the users themselves. Perhaps one of the highest accolades that any interface can achieve is to say that it is transparent. An interface becomes transparent when it is so easy to use that the users no longer think about it, but only about the task at hand. For example, a transparent clinical interface would enable clinicians to focus on patient decisions rather than on how to access or combine patient data from multiple sources. The more transparent the interface, the easier the interaction should be. Usability is a term that denotes the ease at which people can use an interface to achieve a particular goal. Usability of a new human technology interface needs to be evaluated early and often throughout its development. Typically, usability indicators include ease of use, ease of learning, and satisfaction with using, and the efficiency of use, error tolerance, and fit of the system to the task. Some of the more commonly used approaches to usability evaluation are focus group, cognitive walkthrough, heuristic evaluation, formal usability test, and field study. Typically used at the very start of the design process, the focus groups can help the designer better understand users' responses to potential interface designs and to content that might be included in the interface. In a cognitive walkthrough, evaluators assess a paper mock-up, working prototype, or completed interface by observing the steps users are likely to take to use the interface to accomplish typical tasks. This analysis helps designers determine how understandable and easy to learn the interface is likely to be for these users and the typical task. A heuristic evaluation has become the most popular of what are called discount usability evaluation methods. The objective of a heuristic evaluation is to detect problems early in the design process when they can be most easily and economically corrected. The methods are termed discount because they are typically easy to do, involve fewer than 10 experts, often experts in relevant fields such as human-computer technology or cognitive re-engineering, and are much less expensive than other methods. They are called heuristic because evaluators assess the degree to which the design complies with recognized usability rules of thumbs or principles, the heuristics. For example, McDaniel and his colleagues in 2002 conducted a usability test of interactive computer-based program to encourage smoking cessation by low-income women. As part of the initial evaluation, healthcare professionals familiar with the intended users reviewed the design and layout of the program. The usability test revealed several problems with the decision rules used to tailor content to the users that were corrected before implementation. Field study, end users evaluate a prototype in the actual work setting just before its general release. For example, Thompson, Lozano, and Christakis in 2007 evaluated the use of touchscreen computers kiosks containing child health promoting information in several low-income urban community settings through an online questionnaire that could be completed after the kiosk was used. Most users found the kiosk easy to use and the information it provided easy to understand. Researchers also gained a better understanding of the characteristics of the likely users. For example, 26% had never used the internet, 48% had less than a high school education, and the information most often accessed television and media use, and smoke exposure. Dykes and her colleagues in 2006 used a field test to investigate the feasibility of using digital pen and paper technology to record vital signs as a way to bridge an organization from a paper to an electronic health record. In general, satisfaction with the tool increased with use and the devices conformed well to the nurse's workflow. However, 8% of the vital sign entries were recorded inaccurately because of inaccurate handwriting recognition entries outside the recording box, or inaccurate data entry. The data entered were not valid values. The number of modifications needed in the tool and the time that it would be required to make those changes ruled out using the digital pen and paper as bridging technology. There are at least 3 messages the reader should take away from this discussion in this session. First, that there is to be significant improvement in the quality and safety outcomes in the United States through the use of information technology. The designs for human technology interfaces must be so radically improved that the technology better fits human and task requirements. However, that improvement will be possible only if clinicians identify and report problems rather than simply creating workarounds. That means that each clinician has the responsibility to participate in the design process and to report designs that do not work. Second, a number of useful tools are currently available for analysis, design, and evaluation phases of the development life cycles. They should be used routinely by informatics professionals to ensure that the technology fits better both for the task and the user requirements. Third, focusing on interface improvement using these tools has had a huge impact on patient safety in the area of anesthesiology and medication administration. With increased attention from informatics professionals and engineers, the same kind of improvements should be possible in other areas regardless of technologies actually employed there. In the ideal world, one can envision that every human technology interface will be designed to enhance users' workflow, will be as easy to use as banking from an ATM, and will be fully tested before its implementation in a setting that mirrors the setting where it will be used.